Thank you, Dr. Justin Dimick, for talking to OnSurge today. Recently, there was a British Medical Journal article that states that medical errors are the third leading cause of deaths in America. And the author says that uses a very conservative number and is the best existing science in the field. What do you think about the strength of the data?
Well, I think I think we don't know. I don't think we know if it's conservative or not conservative. It may or may not be the best existing science in the field, but I don't think there really is any great science in this field. And the authors themselves point out the reasons for that, and that is that we don't track. We really have no idea how many deaths there are due to medical error, or we really don't have a great handle on when a medical error occurs, whether or not the death or the adverse outcome is actually attributable to that error. I think we know that there's kind of clean-cut medical errors, and then there's a huge gray zone. And the clean-cut medical errors, the things that are considered never events or sentinel events, these are things where you operate on the wrong body part, or there's a clear lapse in medication administration that's the wrong magnitude, or something that leads to a clear patient adverse event or patient death. Those things are actually exceedingly rare. They're very rare, and you may have one or two sentinel events per hospital per year, which compared to total discharges is a very, very small number. So the gray zone are things where care was not optimal, and it may or may not have led to an adverse outcome. So there's a few conditionalities there, and we don't really know. So I think most of these errors and most of these calculations rely on having some idea of how big that gray zone is. Mm-hmm. And so this study, it's unclear whether the number is right or wrong. I think probably the most compelling statement I saw about that number in the aftermath was the general idea that whatever the number is, it's big, it's huge, and it's bigger than it should be. So maybe rather than bickering about exactly what the right number is, we should talk about or all agree on the idea that one medical error or one death from medical error is too many, and we should be working on reducing it. Anyway, that's my general take.
Mm-hmm. So you supported the idea that the author suggests that there's a paucity of data around medical errors. Do you think like you're an outcomes researcher? Do you think if we asked a bunch of outcomes researchers, it would fall to say what is the number 3 cause of death in America, that they would agree that this might be a...
Yeah, I think most people would agree on two things. One, that medical errors are an important area that we need to study and understand and reduce. I think that's clear. That's probably a consensus opinion. The other consensus opinion is that we don't know what the right number is. Yeah. And I've seen people come down on both sides here. Some people say this number is an overestimate because 100% of errors are not preventable. There may be a very small fraction of these errors that are preventable. Even if they're preventable, the patient may have succumbed to their illness if they hadn't have died from that error. So there's a lot of questions about whether or not the number is too large. I've seen some people argue the number is too small because these were hospital-based deaths. There are no doubt a lot of medical errors that happen and can lead to adverse outcomes out of the hospital. So imagine somebody who sees in the ambulatory care setting has a medication interaction effect that leads to sudden cardiac death. Like, that's not captured in these numbers. So the number could be larger. So I think I've seen it argued both ways. I'd say overall, probably I believe, or my best guess would be that this is an overestimate. And part of that comes from my favorite study on this topic, which was published in JAMA in 2001. It was called Estimating Hospital Deaths Due to Medical Errors, Preventability is in the Eye of the Reviewer. That was in the July 25th issue of JAMA 2001 by Rod Hayward, who's a colleague of mine here at the University of Michigan. And what they did was they actually had a panel of internists in a VA hospital review deaths and due to medical errors. And they found something interesting. They found that only about a quarter of those deaths were at least possibly preventable. And everyone kind of agreed that only about 6% were probably or definitely preventable. And if they changed the question and said, what percentage of these patients do you think would have left the hospital alive had optimal care been provided? They agree that only about 6% would have been. So once again, I mean, as a clinician, you know these patients who are dying in the hospital, oftentimes you can, even if you can say that they died of a medical error, or a medical error happened in their care at some point, the attribution of that death to that error is problematic. So I personally think probably it's an overestimate. That does not mean I don't think this is an important issue. And I agree entirely with Marty Macri that having a way to accurately track it is important, and that we need funding agencies, et cetera, to continue to fund work in this area so we can improve safety. Now, as I said before, there's clean-cut medical errors and there's the gray zone. And we don't want to give people the impression that hospitals are unsafe and that surgeons are going around doing crazy things. And I think, as somebody said in the news, we're not sweeping healthy people off the street and succumbing them to medical error in the hospital. I mean, hospitals are filled with well-intentioned surgeons and physicians doing their best to take care of patients. And I'm optimistic about the safety of the healthcare system and the quality. You think about cardiac surgery. We can open people's hearts, stop their heart, restart their heart, and put them in a system that can do that with a mortality rate of 2%. That's pretty safe. In our own field, pancreatic surgery now has an expected mortality around 1%. People are doing portal vein resections with mortality rates at 1%. That's way better than it used to be. So we're getting better at this. I mean, B, that's just a remarkable complexity of care delivered. And so for me, when I think about these issues, I think about the fact that there are errors. The clean-cut ones are rare, and we need to continue to make them more rare. But quality of care is probably more variable, meaning that the proficiency to get patients out of the hospital without complications and without mortality varies tremendously across hospitals. And that's also something that needs a lot of attention and continued attention to. But the one thing is that number is getting lower all the time. For cardiac surgery, for complex surgery, the complication rates are dropping, mortality rates are dropping. So I think there's definitely progress on this front.
Yeah, so it was unfortunate, I think, the way the lay media covered this. In many of the reports, they said these errors are becoming a scary reality in America. In other words, they were reported as if the numbers are rising, the numbers of deaths from medical errors. They would say medical errors are now the third leading cause. And I think unfortunately, the way this article was covered in the lay press gave people the impression things are getting worse.
Yeah, I would say my impression is that they haven't, that they've gotten things have gotten safer, and we know that in our field in surgery, mortality rates have dropped, complication rates have dropped, and in the last 10 or 15 years since the IOM report, surgery is much safer than it was. We have good data on that. Part of that's technological innovation, but a lot of it's just improved systems of care. There's been some centralization of the most complex care in some centers, but there's been a raising of the tide everywhere. So I think it would be misleading to say that hospitals are getting less safe. I think it's an important topic, and we need to keep our eye on it. Certainly, care is getting more complex and more technologically advanced, which opens up the idea for more error. But I don't see any compelling. This is a revision of a number, and the numbers, like I said, we don't know what the right number is. So I think it would be misleading to say that hospitals are getting less safe.
Mm-hmm. So what do you envision for if we had the resources and the grant money and the things you needed to start improving our documentation of errors, and how do you see systems changing, and what would be your goal? You mentioned that you'd like to see more research money for outcomes research. Do you have a broad plan? If somebody says, I'm ready to write a check, what are you going to do with it?
I think it depends on what exactly you're trying to do. I think the error reduction efforts and improving patient safety is a little bit different than improving quality. I mean, there's a lot of funding agencies that are heavily invested in doing comparative effectiveness research and quality improvement. And even the Agency of Healthcare Research and Quality does invest heavily in the patient safety area. But I think that for patient safety in medical error in particular, it's understanding how we can apply principles of systems thinking, of human factors research in our hospitals and health systems, and design better systems for safety. And that's people. There's a lot of folks working on that. There's a lot of people working on that. But a larger investment certainly would accelerate our understanding and knowledge in those areas.
Where does most of the funding come from?
I think for patient safety, probably the Agency for Healthcare Research and Quality, which is separate from the National Institute of Health, and their agenda is directly aimed at quality, safety, and etc. The other funding for healthcare research is the NIH, which funds a lot of work in comparative effectiveness research, some trials, registries, things like that. But it doesn't have as heavily input, or it's not as directly connected to patient safety as AHRQ.
Mm-hmm. Okay. Last words on the state of outcomes research, or on this recent article?
Well, I think, as I said, my closing thoughts on this, I'll probably end with the same 2 points I opened on, are that I don't think this number is the right number. I don't think we know the right number. I don't think it's probably not increasing, but it's a really important topic. And one death that's preventable due to medical error is too many, and I think we need to keep working on reducing that.
Thanks, Dr. Dimick.
Thanks, Chris.
Thanks for checking out the Op Report. Help us keep conversations alive on topics in general surgery. Check out more episodes of the Op Report and other OnSurge content here at YouTube. Find us at Facebook, follow us on Twitter, and find our homepage at onsurge.com. Join the conversation and tell us what topics you'd like to hear about and what people you'd like to hear from.